Welcome back everyone. My today's lesson is about diabetes mellitus in children. When we see the introduction, diabetes mellitus is a common chronic metabolic syndrome which is characterized by hyperglycemia as a cardinal biochemical feature. There are two major types of diabetes mellitus. It is type 1 and a type 2 diabetes mellitus. And there are also other specific types of diabetes mellitus which are not common. Those are genetic defects of beta cell function or MODY, which range from 1 to 11, and genetic defects in insulin action, pancreatitis, trauma, pancreatectomy, and there are also another causes. And also there are gestational diabetes mellitus and neonatal diabetes mellitus. Neonatal diabetes mellitus is a rare genetic disorder which occurs 1 in 90,000 live births, and it's defined by the presence of severe hyperglycemia associated with insufficiency or no circulating insulin occurring mainly before 6 months of age and rarely between 6 months and 1 year. Such hyperglycemia requires either transient treatment with insulin in about half of cases or permanent insulin treatment. The disease is explained by two major groups of mechanisms. The first one is malformation of the pancreas with altered insulin secretion during development or survival, or abnormality in function of existing pancreatic B cell. So, neonatal diabetes mellitus, it is either a transient, which subsides by itself, transient without recurrence, or transient with recurrence, and permanent from the onset. When we see type 1 diabetes mellitus, type 1 DM is the most common endocrine metabolic disorder of childhood and adolescence, with important consequence of physical and emotional development. Individuals with type 1 DM confront serious lifestyle alterations that include an absolute daily requirement for exogenous insulin, the need to monitor their own glucose level, and the need to pay attention to their dietary. Morbidity and mortality is from acute metabolic derangement and also from long-term complication, usually later in life, that affects small and large vessels. The acute complications are due to decay and hypoglycemia, and the long-term complications are related to metabolic disturbance and mainly hypoglycemia. Diabetes mellitus type 2 is rare in children compared to adults. The children and the adolescents with type 2 diabetes are usually obese, but they are not insulin dependent and frequently develop ketosis. But they sometimes develop ketosis during severe infection and other stresses, which is characterized by insulin resistance and often a progressive defect in insulin secretion. The main problem of type 2 diabetes mellitus is insulin resistance, and later it might also affect insulin secretion. The presentation of type 2 DM is typically more insidious than that with type 1 DM, and the history of polyuria and polydipsia is relatively uncommon in these patients, and the incidence of type 2 DM in children has increased recently because of the increased prevalence of obesity in childhood, and also because of the increased lifestyle, which is less ambulatory and which predisposes a child for metabolic problems. Acanthosis nigricans, which is a dark pigmentation of skin crease or flexure areas, is a sign of insulin resistance, and it is present in the majority of patients with type 2 DM, and it's accompanied by relative hyperinsulinemia at the time of diagnosis. So let's discuss about type 1 DM, which is more common in pediatrics. The onset occurs predominantly in childhood with a median age of 7 to 15 years, but it might present at any age. The peaks of presentation occur in a two-age group at 5 to 7 years of age and at the time of puberty. Now, a day we see more patients who are under 5. Even nowadays, neonatal DMs are becoming more common. And type 1 DM is associated with other autoimmune diseases such as thyroid, celiac disease, and also Addison disease. There appears to be no gender difference in the overall incidence of childhood type 1 diabetes, and genetic susceptibility. The risk of type 1 diabetes is significantly increased in a close relative of a patient with type 1 diabetes. And also there are some environmental risk factors that increase the chance of developing type 1 DM. In a genetically susceptible individual, exposure to one or more environmental agents appear to trigger an immune response that ultimately causes a destruction of the insulin-producing pancreatic beta cell, such as virus, cow milk exposure, certain drugs from the virus, such as rubella, and the like. They predispose a genetically susceptible individual to develop type 1 diabetes mellitus. 10% of the children with diabetes have diabetes type 1 among relatives. If both parents are affected by type 1 diabetes, they will have a child with diabetes in about 20 to 25%. If one parent is having type 1 diabetes, about 5%, which is less if the mother has a diabetes and higher if the father has a diabetes, will develop diabetes mellitus. If one sibling with diabetes is there in the family, the risk is about 5%. And in a twin, especially in identical twin, the risk of having another twin to have diabetes mellitus if the first twin has a twin is diabetes is 30 to 40%. When we see the natural history of type 1 DM, it includes 4 distinct stages. The first one is preclinical beta cell autoimmunity with a progressive defect of insulin secretion. This is followed by the onset of clinical diabetes, and this is followed by transient remission or honeymoon period, and this latter established diabetes associated with acute and chronic complication and the decreased life expectancies occur. When we see about pathogenesis of type 1 diabetes mellitus, the autoimmune attack on the pancreatic isolates leads to a gradual and a progressive destruction of B cells with loss of insulin secretion. And it is estimated that at the onset of clinical diabetes, 80 to 90% of the pancreatic isolates are destroyed. And regeneration of new isolates has been detected at onset of type 1 DM, and it is thought to be responsible for the honeymoon phase. That means a transient decrease in insulin requirement associated with improved beta cell function. So honeymoon period is due to a regeneration of new isolate cells. When we see physiology of type 1 diabetes mellitus, insulin is our most important anabolic hormone. Saving, storing, and upbuilding of carbohydrate, protein, and the fat is the main anabolic function of insulin. When we see the effect of insulin on a carbohydrate, insulin stimulates the insulin receptor on the cell surface GLUT4 or a glucose transporter, and is sent to the cell surface of the muscle to pick up glucose by endocytosis. And the more insulin our body have, the more transporter of glucose. And glucose is phosphorylated and ready for either storing as a glycogen or glycolysis and energy production. When we see the effect of insulin on fat, insulin preserves the fat stores. It antagonizes the renal sensitive lipase in a fat tissue. So it preserves the store of fat. When we see the effect of insulin on protein, amino acid uptake in the cell is stimulated and the breakdown of protein is reduced when there is more insulin in our body. Insulin levels must be lowered to then mobilize stored energy during fasted state. Thus, in a normal metabolism, there are irregular swings between the postprandial high insulin anabolic state and the fasted low insulin catabolic state that affect liver, muscle, and adipose. So, when we see the effect of high plasma insulin or low plasma insulin on the different organ system during postprandial state, which is a high plasma insulin level, it causes glucose uptake, glycogen synthesis, lipogenesis, and absence of gluconeogenesis and ketogenesis on the liver. And it causes glucose uptake, glucose oxidation, glycogen synthesis, and the protein synthesis on the muscle. And it causes glucose uptake, lipid synthesis, and the triglyceride uptake on adipose tissue. The opposite happens when there is a fasted state or low plasma insulin level. Hyperglycemia produces an osmotic diuresis or glycosuria when the renal threshold is exceeded at around 10 millimole per liter or when our blood glucose level exceeds 180 milligram per deciliter. The resulting loss of calories and electrolytes as well as the persistent dehydration produce a physiological stress with hypersecretion of stress hormones such as epinephrine, cortisol, growth hormone, and the glucagon. So these hormones in turn contribute to the metabolic decompensation by further impairing insulin secretion by, for example, by epinephrine, and also by antagonizing its action. Epinephrine, cortisol, and the growth hormone antagonize insulin action, and also by promoting glycogenolysis, gluconeogenesis, lipolysis, and the ketogenesis. Glucagon, epinephrine, growth hormone, and the cortisol all can cause those things. And also epinephrine, growth hormone, and the cortisol can cause decreasing glucose utilization and glucose clearance, impairing insulin secretion, antagonizing the available insulin action, and decreasing glucose utilization, and also increasing gluconeogenesis and the ketogenesis are the main pathophysiology that occurs in diabetes mellitus. When we see the effect of absence of insulin by diagram, lack of insulin action causes proteolysis and lipolysis. This proteolysis and lipolysis cause weight loss, and lack of insulin action causes hyperglycemia. Hyperglycemia causes glucosuria. Glucosuria causes osmotic diuresis, which predispose for polyuria, and the polyuria causes dehydration, and this polyuria and dehydration contribute for polydipsia and weight loss. And also lack of insulin action causes ketogenesis. Ketogenesis causes acidosis, and it causes hyperventilation and nausea. And also this ketosis causes polyuria. So the basic thing that happens in type 1 diabetes is lack of insulin, which causes lack of insulin action, and it end up in weight loss, polyuria, polydipsia, acidosis, and all clinical manifestations of type 1. When we see the clinical presentation of type 1 diabetes mellitus, children with a type 1 diabetes can present in several different ways. They can present as a classic new onset type 1 DM, and 20 to 40% of them may present as a diabetic ketoacidosis, and the rest is incidental discovered. So we call them a silent or asymptomatic type 1 DM. Classic new onset DM is defined as hyperglycemia with acidosis, without acidosis. So hyperglycemia without acidosis is the most common presentation of childhood type 1 diabetes. And symptoms are caused by hyperglycemia, and it includes polyuria, polydipsia, weight loss, and lethargy. As a diabetes develops, symptoms steadily increases, reflecting the decrease in beta cell mass, worsening insulinopenia, progressive hyperglycemia, and eventually ketoacidosis. Initially, when only insulin reserve is limited, occasionally hyperglycemia occurs. When the serum glucose increases above the renal threshold, intermittent polyuria or nocturnal begins. With further beta cell loss, chronic hyperglycemia causes a more persistent diuresis, often with nocturnal enuresis, and polydipsia becomes more apparent. Female patients may develop vaginal candidiasis due to the chronic glucosuria. The second clinical presentation of type 1 diabetes in children is diabetic ketoacidosis. Children with type 1 diabetes often present with a diabetic ketoacidosis, that means hyperglycemia with ketoacidosis, and the symptoms are similar, but they are usually more severe than those of a patient without acidosis. The reported frequency of diabetic ketoacidosis at the initial presentation for childhood type 1 diabetes varies from 50 to 67%, based on literature and based on also the area of study. In our setup, in our country, more than 80% of patients present with a DKA at the initial presentation. As an initial presentation, or in a known case of DM, when they omit insulin or when there is infection or stress. So, a child with type 1 diabetes can present with a DKA, one from the outset at presentation, or second as the initial presentation, or in a known case of DM when they omit insulin or when there is an infection or stress. And we can classify this DKA as mild, moderate, and severe DKA. We classify mild, moderate, and severe based on the venous pH, clinical manifestation, and also bicarb level. Most of the time we use the clinical system in our setup. We say normal if there is no change in mentation, and if the patient is alert, conscious, and if the patient is overall stable. And we say mild if the patient is alert but fatigued, and we say moderate DKA if there is cosmolus breathing and the patient is sleepy or lethargic, and we say it's severe if the patient is comatose. And also we can use venous pH if available. We say severe if it is less than 7.15, and we say moderate if it is between 7.15 and up to 7.25. We say mild if it is from 7.25 to 7.35. When extremely low insulin levels are reached, keto acids accumulate, and the keto acids produce abdominal discomfort and nausea and also emesis. Dehydration accelerates, causing weakness, and the polyuria persists. As in any hyperosmotic state, the degree of dehydration might be clinically underestimated. Because the dehydration is intracellular. In a hyperosmotic state, the dehydration is intracellular, so the degree of dehydration might be clinically underestimated. Ketoacidosis exacerbates period symptoms and relates to cosmolus breathing, that means deep and heavy and rapid breathing, and also fruity breath odor due to acetone, and also diminished neurocognitive function, and possibly it might lead to coma. When we see the third clinical presentation or silent presentation, some children will be diagnosed with type 1 diabetes before the onset of clinical symptoms. And this presentation is the least common presentation, and it typically occurs in children who have another close family members with type 1 diabetes, and they are being closely monitored, and we detected them, we identified them before they develop a symptom. Well, just overall to diagnose diabetes mellitus, we need one of the three criteria. The first criteria is fasting plasma glucose greater than or equal to 126 mg per dl or 7 millimole per liter on a 2 occasion, or symptoms of hyperglycemia and a random venous plasma sample greater than or equal to 200 mg per dl and hemoglobin A1C greater than 6.5%. So one of the three can diagnose both type 1 and type 2 DM. When we see the management of diabetes mellitus in children, mainly type 1 diabetes, challenges in a pediatric DM care is there. Compared to adults, there is a lot of challenges in treating and in monitoring, and also in taking care of a pediatric DM care overall. These challenges are, there are unique challenges in caring for children and adolescents with diabetes that differentiate pediatric from adult care, and this include the obvious difference in the size of the patients and developmental issues such as unpredictability of a toddler's dietary intake, unpredictability of toddler's activity level, and also medical issues such as increased risk of hypoglycemia and diabetic ketoacidosis. Because of these considerations, the management of a child with type 1 diabetes must take into account the age and also developmental maturity of the child. The goals of management of diabetes in a child is successful management of children with diabetes includes balancing strict glycemic control, which reduces the risk of long-term sequelae, and avoidance of severe hypoglycemia, which is more likely with stricter control. So strict control predisposes a child for hypoglycemia, whereas poorly controlled predisposes a child for hyperglycemia and also risk of long-term sequelae. So we should have to balance those things when we treat a child with DM. In a children, targeted glycemic goals define what is thought to be the best balance between those long and short-term complications. Maintaining normal growth, development, and emotional maturation is also our target, and increasing self-independent management as a child grows is an ongoing goal also. And training the patient and the family to provide appropriate daily diabetic care in order to attain glucose control within the range of predetermined goals and to recognize and treat hypoglycemias are another goal. Overall, if a patient presents with a DK, we should have to manage a DK. DK management have around 6 to 7 components. The first one is expanding intravascular volume, then rehydration therapy, potassium replacement therapy, insulin therapy, avoiding and treating complications such as hypoglycemia, cerebral edema, and hypokalemia during treating a DK, and treat precipitating factors, and the follow-up of patient after discharge. The first component of the DK management is fluid requirement. Bolus fluid 10 to 20 ml per kg of normal saline to be given over 1 hour is needed, and it can be repeated if necessary. And the maintenance fluid for 48 hours is calculated, and we should have to add this maintenance fluid to the deficit fluid, which is calculated as 85 ml per kg, considering 8.5% dehydration. We should have to subtract the bolus, and we should have to divide after adding deficit plus maintenance fluid for 48 hours, and we divide it by 48 hours with 40 millimole potassium in each 1000 ml of normal saline, and we administer this maintenance fluid for 48 hours. And the potassium replacement therapy is required regardless of the serum potassium concentration, and we should have to make sure that the child is passing urine before initiating of KCL. And always keep mannitol at the bedside because of the risk of cerebral edema while treating a DK. The other component of DK management is insulin administration. Start insulin infusion 1 to 2 hours after starting fluid management. That means after starting intravascular volume expansion. And if you have a perfuser, we can start with regular insulin 0.1 international unit per kg per hour. For example, by diluting 50 international unit regular insulin in 50 ml NS, we make it 1 unit is equal to 1 ml. So we can give 0.1 international unit per kg per hour or 0.1 ml international per kg per hour. low dose IV insulin administration should be standard of care always. And the current practice in our countries, where we don't have adequate perfusion and adequate follow-ups, we can start with 0.5 international unit per kg regular insulin every 6 hours. And the first dose is half IV and half subcutaneous, and then we continue with 0.5 international unit per kg subcutaneous every 6 hours. So after giving the first 0.5 international per kg every half IV and half subcutaneous, the second dose is continued by 0.5 international per kg subcutaneous. When we treat DKA, don't omit insulin is the key. If there is a rapid decline of glucose greater than 90 mg per deciliter per hour, we can decrease the dose of our insulin by 50%. That means if we are giving 0.1 international unit per kg per hour, we can decrease it to 0.05 international unit per kg per hour, and we can change the fluid to half normal saline and half 10% DW. And consider adding glucose even before plasma glucose has decreased to 250 to 300 mg per dl. And continue the management until the child is out of decay. If you can do ABG, we can say a patient is out of decay if patient is conscious, pH is greater than 7.3 and the bicarb is greater than 50 millimole per liter. In our case, until the urine is ketone free. And to prevent rebound hyperglycemia, the first subcutaneous injection should be given 1 to 2 hours before stopping the insulin infusion to allow sufficient time for the insulin to be absorbed. Potassium can be given as a potassium phosphate or as a potassium acetate or as a potassium chloride with a rate of 0.5 millimole per kg per hour. Most of the time 40 millimole per liter of fluid. When we treat DK, we should have to also strictly follow for the possible development of complications. From the most common complication in DK management is hypoglycemia, cerebral edema, hypokalemia. So we need to follow strictly with vital sign, frequent random blood sugar measurement every 2 hours, and also electrolyte measurement every 4 hours. And also bedside mannitol should be available at 1 gram per kg because of the risk of cerebral edema. After treating DK, the next treatment is replacement therapy. And since type 1 diabetes mellitus is due to deficiency of insulin, insulin therapy is needed long term, and children with long standing diabetes and no insulin reserve requires about 0.7 international per kg per day if pre-pubertal age, and 1 international per kg per day at mid-pubertal, and 1.2 international per kg per day by the end of puberty. This is the starting insulin level, but we can decrease and increase based on the patient's blood sugar during follow-up. The other thing is basic education about insulin injection, about meal planning, about exercise, about symptoms of hypo and hyperglycemia, and also importance of self-monitoring of blood glucose and the impact of poor control of DM. So we should have to strictly educate the family and the patient about those basic things. Insulin preparation kinetics following subcutaneous injection. Most of the time for DK management, we use regular insulin in our setup. Regular insulin has onset of action between 30 to 60 minutes and the peak of action from 2 to 4 hours, and the duration of action is 6 to 8 hours. So most of the time we give regular insulin QID if we are managing DK. There are also other long-acting and also other types of insulin such as lisproaspart, which is rapid-acting, NPH, which is long-acting, and also glargine, and the other combinations are available. The other thing is about mode on the types of insulin injection. There are different ways of insulin injection. The first one is conventional way or twice daily injection that we are using it most of the time. And regular insulin with intermediate acting insulin such as NPH or lent insulin should be used during conventional way. So we should not use regular insulin as a conventional or twice daily injection, and also we should not use NPH or lent insulin alone as a conventional way, except in special circumstances. And the other ways of insulin injection is multiple daily injection using basal and bolus insulin. The basal is most of the time by glargine, and the bolus is most of the time lisproaspart and regular insulin. And the third and the recently advancing mechanism is continuous subcutaneous insulin injection or pump therapy using short-acting insulin. So conventional way, multiple daily injection and continuous subcutaneous insulin injection or pump therapies are the three currently available and the possible insulin techniques. When we see the nutritional management, the nutritional content of a child with a diabetes should include carbohydrate 55%, fat 30%, and protein 50%. And the carbohydrate should be a complex carbohydrate. And the total daily calorie intake is divided to provide 20% at breakfast, 20% at lunch, and 30% at dinner, leaving 10 for each of the mid-morning and the mid-afternoon, and also evening snacks if they are desired. The other issues about target blood glucose level when we treat a child with diabetes mellitus. Monitoring blood glucose level by self-monitoring of blood glucose. Insulin dose adjustment is needed. Ideally, the blood glucose concentration should range from approximately 80 mg per dl in the fasting state to 140 mg per dl after meals. But this strict control is difficult in a child because of the risk of hypoglycemia. In our practice, most of the time we accept a range of 70 to 250 mg per dl glucose level. So targeted blood glucose and hemoglobin A1C level based on the age is as follow. As you see on the table, for less than 5 years, the target hemoglobin A1C is from 7.5 to 9. To avoid the risk of hypoglycemia, we tolerate a higher amount of hemoglobin A1C. For 5 to 11, 6.5 to 8. For 11 to 15, 6 to 7.5. Hemoglobin A1C is a reliable index of long-term glycemic control. It is provided by measurement of glycosylated hemoglobin. And this hemoglobin A1C represents the fraction of hemoglobin to which glucose has been non-enzymatically attached in the bloodstream. Because of the half-life of red blood cells around 120, it will be measured 3 to 4 times a year. In an diabetic individual, the hemoglobin A1C fraction is usually less than 6. In diabetes, the value from 6 to 7.9 represents good metabolic control, and the value from 8 to 9.9 is fair control, and a value above 10 is poor control. So we should have to have hemoglobin A1C every 3 to 4 months when we follow diabetic child, and we label a patient as a good control, fair glycemic control, and a poor glycemic control based on the level of hemoglobin A1C. And we take, if the patient have, for example, hemoglobin A1C of 11, this is a poor glycemic control, and we should have to search what is the cause of poor glycemic control. Is that treatment failure? Is that an inappropriate dose? Is that inappropriate storing of insulin, or is that injection technique, or is that exercise, meal, and something? So we should have to search for the cause of poor control. Regarding exercise, no form of exercise, including competitive sports, should be forbidden to the diabetic child, but the risk of hypoglycemia is there during or within hours after exercise. So blood glucose measurement is important, and they have to take candy or soft drink immediately if there are symptoms of hypoglycemia. Other important issues in managing diabetes in children is hypoglycemic prevention in the management, and also sick day management, and issue of adherence, and also management during stressful time and the surgery. And the diabetic addiction is also the main component of management of diabetes. Just to see the management of type 2 diabetes mellitus in child highlightly, weight loss and the physical exercise are said to be the main strategies in controlling glucose level in a type 2 diabetic patient. And oral hypoglycemic agents like metformin can be tried, and also insulin if they have when we see the prognosis of diabetes mellitus in children, overall their lifespan is said to be 10 years shorter than the same age person who do not have a diabetes mellitus. And the visual, renal, and neuropathic complications are common, and the puberty might be delayed, and also the final height is less than that of the genetic target. So thank you for your attention, and also thank you for subscribing this channel.